All right, good morning. Welcome. We're going to get started. How's everybody doing? Good. All right, so we're very pleased to have one of our own, Danielle Jose Gastambide. Saidi is a staff psychologist here at Mount Sinai-St. Luke's in the outpatient clinic and assistant professor of psychiatry at the Icahn School of Medicine. He did his internship and his postdoctoral fellowship here, and we're very glad that he has stayed on with us to continue his good work. So he's not only doing clinical work, but has worked on issues around race, culture, and psychotherapy. He earned an inaugural 2014 Multiculturalism and Psychoanalysis Award from the NYU Postdoctoral Program in Psychotherapy and Psychoanalysis. He served as a liaison, the Division of Psychoanalysis, to the Committee on Ethnic Minority Affairs of the American Psychological Association, and assists there in developing public policy related to mental health access and ethnic minority mental health. And he was involved in an interesting project of a documentary film called Psychoanalysis in El Barrio, interviewing 9 Latino psychologists, talking about the challenges and excitement of clinical work with Latino patients affected by poverty using psychoanalytic, psychological principles. He's written academic articles as well on a range of topics on Latino identity, psychotherapy, race and culture, religion, and spirituality. So we're very pleased to welcome him today, and take it away.
Great, thank you so much, Paul. Can everybody hear me okay with this mic? It's always important to test that out. Okay, so I'd like to talk to you all today about some writing that comes out of some recent scholarship I've been working on related to race and clinical care. In an era and a time that's probably very challenging and very difficult to talk about these things, both at a clinical level but also amongst ourselves as professionals. Now, we look at mental health disparities research for ethnic minority populations. There are a number of barriers to care that have been looked at, that have been examined very closely, among them cultural stigma, meaning the values and concerns that different communities have about mental health or psychiatric care, as well as lack of access to be able to actually attain services when there's actually a desire to pursue them. But more recently, there's also been a growing attention being devoted to clients who get through their cultural stigma, are able to have access to care, but then experience very negative interactions with mental health providers, which may place them at much higher risk of dropping out of care. Part of the reason this is important is because ultimately our work as social workers, psychiatrists, clinical psychologists is profoundly relational in nature. The relationship, as I'm sure we all know, provides the ground and scaffolding that allows our work and our interventions to happen, but the relationship itself is curative, regardless of whether you're doing psychotherapy as such. I mean, for example, really recently had a client who was talking to me about scheduling some time with their resident, and had the experience of saying to the resident, you know, it would be really good for me if we could do it on this day, but I don't want to inconvenience you. And the resident responded by saying, well, you're not going to inconvenience me. Let's find a time that works for both of us. And for somebody with a long history of feeling rejected and despondent, to have someone being so open and compassionate was itself very curative and warm and open. Now, in focusing on race and racial difference today, we're trying to be mindful about factors that could impact the relationship. And the argument that I want to develop today is that actually in keeping race in mind in our therapeutic relationships, as opposed to rendering them invisible, we can actually make our relationship stronger. Now, the Working Alliance in particular has also had a lot of attention more recently in looking at health disparities, and I'll be focusing on that later towards the presentation. But first, I want to address a couple of premises regarding anxieties about talking about race. Presentations like this one sometimes evoke anxieties and fears about the goal of the presentation, such as, is somebody going to tell me or us or institution that we're bad, or that we're racist, or that we're ignorant or insensitive in some way. It can also lead to feelings of anger towards the presentation. Well, I'm not the bad one. The person talking about these issues is the bad one. Or some sort of doubt about one's own sense of goodness in talking about these issues. Now, when people experience these feelings and doubts, often they engage in a number of maneuvers to try to preserve and protect their sense of self, which feels in some ways critiqued or under scrutiny by these conversations. However, research has actually shown that when we're able to approach these topics as a learning opportunity, something from which we can grow, and it's something that is a teachable, learnable skill, and in turn experience our sense of self as fluid. And what I mean by that is that we see our sense of self as something that is open and that is capable of growth and change as opposed to something fixed, meaning that we're either good or bad, or that we're somewhere in between, somewhere always emerging. This makes it more likely for us to be able to not just obtain the information, but to be able to have real conversations, to be able to listen to each other. So I posed the following premises for today. Firstly, that cultural competency and the topics that I'm going to discuss are teachable, learnable skills. That we're not good or bad, but we're always growing and understanding more, that we make mistakes, but we can learn from them. And I want to share with you a mantra that we discuss a lot in the psychotherapy world and psychiatry, which is that it's not the presence of a rupture, but the absence of repair that often leads to problems. So not the presence of a mistake, but what it is that we do in the aftermath, how it is we cope, how it is we relate to the other person, and trying to make sense of what has happened. And this is part of the underlying philosophy of what I'd like to talk to you about today. Let me break down a couple of definitions first. What we mean in this particular research between explicit and implicit attitudes. By explicit attitudes, we usually refer to beliefs and attitudes about concepts, things, or ideas, or people that we can readily and without effort bring into awareness. So for example, I can speak at length about what I think and feel about cheesecake, right? I can retrieve it very quickly and immediately into my mind. However, this is distinct from one's implicit attitudes, which are automatic, often non-conscious beliefs and attitudes that operate outside of awareness and without conscious reflection. This is in turn often reflected in our affect, how we feel, especially our organic affect, and also our behavior in relation to others. Now, in relation to cheesecake, if I were to take a moment and let my mind sort of associate, I would probably come to not just cheesecake and its various flavors, but to different experiences that I've had with cheesecake and the emergent properties that arise in my body, such as joy, happiness, excitement, taste, right? Now, these are often harder to bring into focus, but if we're able to slow ourselves down and sort of reflect a little bit, things become a little bit more transparent. The issue, both in general in terms of non-conscious processes, but especially in regards to bias, is that we don't have a space to reflect. And so we're much more likely to depend on automatic neurocognitive processes. Now, in order to assess for different types of implicit attitudes, there's a particular test that's been researched widely in social psychology called the implicit association test. This test examines the strength of association between concepts such as black or white and affect or evaluation, good or bad. The way that this test works is that subjects are instructed to very quickly and without further thought to sort or evaluate words or pictures as either good or bad as quickly as possible. So for example, somebody might be instructed that they're going to see a number of pictures. And whenever they see a picture of a discernibly African-American person, they're to click the key that designates that picture as good. And whenever they see a picture of a discernibly white person, they're to click the key that discerns it as bad. And then you do the same exercise, but in reverse. Part of what this test looks at is that their reaction time between associating one concept with a positive valence or good and another concept with a negative valence or bad. So in other words, if somebody is more quickly or more automatically able to associate, for example, white with good and black with bad, but then when they're asked to associate them in the reverse, there's a delay. In other words, cognitively, something hits on the brakes and has to engage in more conscious thought to be able to make that association happen. This yields then essentially a disparity or a bias in terms of how somebody's automatic cognitive processes function. In other words, being more likely to associate goodness with white and more likely to associate blackness or the idea of a black person with what is bad. Now, let me break down a couple of important distinctions between explicit and implicit bias. We could have, hypothetically, someone who at an explicit level is readily able to describe essentially a lack of bias towards a target person or group. And when conducting this particular test, they may not show a bias between one group or the other, right? So low explicit bias and low implicit bias. You could also have the reverse, where someone is readily able to speak about their particular prejudices or negative feelings towards a person or a group, and then when they engage in this particular test, they also show very high implicit bias. But more interestingly, are folks who, when they're giving an explicit measure of bias, or they have to literally fill out their thoughts and feelings about particular groups, they may report very minimal bias, but when engaging in this implicit attitudes test, they reveal a much higher implicit non-conscious bias against the target person or group. And a lot of the research that I'll be talking about today looks at this latter group of folks who consciously reports not having any kind of bias or prejudice, but at an implicit level, particularly in their behavior, may evidence a difference in how they treat different persons or groups. I'm going to take a look first, give you sort of a sample of the kind of research that's been done, starting with general medicine. Overall, it's been shown that in general medicine, when they have primary care physicians engage in this particular test, they do show some form of bias against particularly African American and other people of color. Now, when they do studies where they look at the difference between a physician's explicit bias or their implicit bias, they find firstly that they tend to have very low explicit bias, but some physicians will have very low explicit bias and very high implicit bias. And when they look at how patients rate them in terms of how they interact with them, their level of interpersonal warmth, they find that physicians who score more highly on implicit bias tend to be rated by their patients as having less interpersonal warmth, as being more domineering in the therapeutic interaction, and to have a less sort of affable and empathic connection. In other words, a poorer rating of interpersonal treatment, trust, but also knowledge. It's also been found that for physicians who have higher implicit bias, they tend to be much more authoritarian with their clients of color. They tend to be much more domineering in the interaction, which also in turn impact whether the patient will then carry out their recommendations. Now, a much more recent study I wanted to share because I thought it was very interesting, actually did a randomized experiment where they took physicians, had them complete explicit measures of bias and the implicit association test, and then they randomized the physicians to whether they would be treating a white patient or an African American patient. And what they found overall, especially when they had some videos in the study, what they found is that when they looked at the physician in relation to the white clients, they tended to be much closer, tended to engage in a lot more physical touching, more warmth in their tone, more smiles, more signs of closeness and some kind of affability. However, when they looked at physicians who had high implicit bias, with their African American clients, they would be much more distant, both physically, in the way that their demeanor was oriented towards them, engage in less smiling responses, and there would be less, one might say, sort of bedside manner in how they'd interact with the patients. Also important to note is that in this particular study, there was also some evidence that this affected intervention. In other words, the likelihood of referring a client for life-saving care. Also important to note, the information that the physicians provided to their patients tended to be essentially the same. So even though the education and talk about the treatment options they were giving their clients were similar, the level of interpersonal closeness and also the likelihood of referral for care was much different. Skip ahead a little bit in the interest of time. Now, another very important wrinkle to this conversation is the role of empathy. In this series of studies I'm going to talk to you about right now, it's been shown that in general, even though white patients and black patients tend to report sort of equivalent ratings of pain depending on their condition, overall African American patients are less likely to be to be prescribed pain management medication compared to white patients. When they looked at the role of bias, they found that indeed, once again, physicians who had high implicit bias, particularly pro-white bias, had a reduced likelihood of providing opioids, in this case for black children with post-operative pain. Now, in another study, they did a very interesting intervention when they took, in this case, the nurses, and they explicitly instructed a group of nurses to literally think about the kind of pain that the patient is going through, to empathize with that pain, to think about it a little bit before making their decision. And then another group of nurses where they did not ask them to slow down and engage in this reflective and empathic process. And what they found is that in the group that they asked the nurses, they didn't, now, mind you, they didn't specifically say to do this in terms of race, but they asked them specifically to just slow down and try to empathize with what the patient is going through. Those nurses were more likely to prescribe opioid medication to both white and black patients. In other words, there was no disparity, which suggests, again, that there's something about implicit bias that impairs an underlying human capacity that we all have for empathy, for making connections, and then the interventions that derive from that. Now, this is, of course, a much broader issue than general medicine or let alone psychiatry. This fits into a much broader body of research that looks at interracial interactions, both in clinical medical settings, but also in pedagogical settings, in schools, in colleges, and also day-to-day interactions. More recently, there was a particularly interesting meta-analysis looking at interracial interactions. And that meta-analysis showed overall that participants, meaning both participants in interracial dyads, tended to have more negative attitudes towards their partner, more negative affect, particularly anxiety about the interaction, less friendly, nonverbal behavior. And in cases where the dyads were assigned a task or a problem to solve, they tended to have poor outcomes, so much less likely to solve a problem or address an issue. Now, these differences apparently were reduced when there was some sort of shared identity, particularly along the lines of gender, or when the interaction itself was structured, meaning they were given a script with which to interact with. That seemed to make outcomes a little bit better. Now, part of the reason within social psychology why there may be these long-standing historical difficulties in interpersonal relationships has to do with what's called intergroup contact, which is based on Gordon Allport's work. From Gordon Allport's perspective, he theorized that prejudice and bias results from a lack of knowledge about the out-group, anxiety about what engaging in interaction with that out-group might look like, and a difficulty making an empathic connection with the out-group, coming down at the end of the day to a lack of ongoing, real, three-dimensional contact with out-group members. Inversely, research has shown that when folks are able in their day-to-day lives to develop not passing, not fleeting, but real, genuine, day-to-day connections with people from cultural and ethnic groups outside of them, they were not only able to enhance their knowledge about the group, to have a three-dimensional picture of members of that group as opposed to depending on an automatic stereotype. They were able to reduce their anxiety about having interaction with out-group members, and perhaps more importantly, they were able to increase their capacity for empathy and perspective-taking with the out-group. And all three of these factors, in turn, have been shown to reduce bias. Of the three, however, it's been shown that the affective dimension, meaning the person's level of anxiety and their capacity for empathy, were much more predictive in reducing bias than just receiving knowledge, which I think is very important to think about in terms of multicultural training, both among psychiatry and psychology trainees, because often we focus a lot on giving people knowledge, but that knowledge sometimes doesn't trickle down into affecting our basic emotional systems, our capacity for empathy, our capacity to be comfortable with engaging with the other, which is something I'll come back to later in the presentation. Now, there are direct as well as indirect forms of contact. Direct contact referring to actual engagement with people face-to-face. But indirect contact has also been shown to exert a very positive effect, meaning, for example, virtual contact, having interactions with people over the internet, or watching shows that have a diverse cast, what used to be called the so-called Will and Grace effect. Right? Where it was theorized that having the show Will and Grace on air had some sort of impact on people's understanding and depiction of people who were gay, transgender, bisexual, lesbian. Right? That it was able to shift the culture by just having the representation of these different marginalized groups. There's also extended contact, which means having a friend who themselves has connections with out-group members, but also very interestingly, imagining an interaction with someone who is an out-group relative to you. At least in an experimental context, it's been shown that when people are engaged in almost a kind of mindfulness exercise about interacting with difference, this seems to have some effect in reducing bias as well. Now, one very important mechanism that seems to underlie the effectiveness of contact is that being exposed to difference in an intimate, protracted way seems to unfreeze our cognitive processes, what's called epistemic unfreezing, that rather than depending on an automatic and at times non-conscious form of information, we're able to engage much more deliberately and reflectively. In other words, we open ourselves up to new information about out-group members, new ways of being able to relate and understand the other. Interestingly enough, this has been found to be almost a kind of skill that spreads out from the particular interactions. For example, if somebody engages in increased interactions with folks based on race or ethnicity, that also seems to affect our capacity to be more understanding of, say, sexual minorities. That there might be some part of our brain that is actually involved in detecting, regulating, and engaging with difference. And the more that we exercise that capacity of our brain to deal with difference, the more capable we might become of actually engaging, noticing, and reacting more effectively with people from diverse groups, not just in terms of race or class. Now, to summarize the story thus far, we've reviewed how a potential source of discord in interracial relationships are the implicit biases that one or both members of the relationship may hold. This bias in turn is maintained by anxiety and difficulty being able to make an emotional, empathic connection. However, this bias may be reduced when we have sufficient intimate and contradictory positive experiences. Now let's turn to mental health. When we look at the world of mental health, there seems to be sort of unanimous understanding among patients and among administrators that yes, cultural stigma plays a big role in why people may not be able to receive care. Structural imbalances, of course, also play a big role. But patients and administrators, and not so much clinicians, agree that clinician bias may also play a role. So there seems to be some understanding from outside our immediate role as providers that our own beliefs, realities, the capacity to engage may impact patient care, and clinicians may be a little slower on the uptake. Now, for the information I'm going to share with you right now, let me just cover some basic definitions in terms of the therapeutic alliance. The therapeutic alliance consists of not just our emotional bond with the patient, but our capacity to have some sort of agreement or negotiation on what the tasks and treatments are going to be, what the goals are, and then being able to explore not just the immediate goals of the treatment, but also how the patient may see those goals and see their presenting problem, particularly in the cultural milieu may be important. But we also know that over time there may be moments in which there is a disagreement on the goals of treatment, or some breach in the empathic relationship, what are called ruptures in the therapeutic relationship, or there may be some discord in the alliance. Now in the literature we speak about little r ruptures, which are little tears that take place over time in the relationship, and which may be in a sense invisible, particularly to the clinician, and thus more difficult to detect, as opposed to big R ruptures, which may be more dramatic incidents of overt hostility or withdrawal in the therapeutic relationship. Tension is defined, just to put it succinctly, as a tension or a breakdown in the collaborative relationship between the provider and the patient. And these can often be detected by what are called rupture markers. In other words, if the patient suddenly withdraws in the relationship, or if they become suddenly very hostile towards the clinician, right? Now, these kind of behaviors may suggest that there's some sort of way in which the relationship has gone off the rails or gone awry. Now, we also know that there are ways of being able to address these ruptures, to be able to address them with the patient in an overt, conscious way, to be able to repair and restore the relationship. Now, from this rupture resolution model, there's an importance that's placed on mindfulness and being humble in relation to the patient, for the clinician to have an awareness of their moment-to-moment feelings, but also have an understanding that those feelings do not define them in these moments, that just because there is a rupture does not mean the therapist is bad, but that there's something the therapist and the patient need to talk about, that there's some growth that can come from this moment in the relationship. Relatedly, that the therapist, the provider, can also accept responsibility for their contribution to their impasse. Right? which may mean that there is some germ of truth in what the patient is saying or reporting to them. Not necessarily that it's entirely true, but that there's some information that needs to be discussed in the relationship. And that lastly, that the patient be empowered by the empathic connection, but also the validation of what has happened. You know what? Maybe there was some terseness in my voice when I was talking to you just now. You know what? Maybe I think I did become disengaged in this moment. Let's talk about what that might mean for us. Overall, we know this from our clinical work, but also there's some research that shows this to be true, that when we're able to accept responsibility and engage in this repair process, the alliance becomes stronger, patients are much more likely to stay in treatment, and they're likely to get better. Now, when it comes to the issue of taking responsibility for a transgression, research has shown that we're much more likely to accept responsibility depending on how it is we see our sense of self. Okay? When we transgress, whether it's in psychotherapy or medication management or in our day-to-day relationships, sometimes it's difficult for us to accept responsibility because we're afraid that that then means that we're a bad person, right? That making a mistake in our friendship or in our relationship may not only mean that there's something you need to talk about with that person, but may mean that you are bad. And so in order to then deal with that sense of badness, you may deny, right? You may minimize the problem that has transpired with the other person. And part of this has to do with the way that we see ourselves. There's this idea of implicit theories of personality, meaning how we see our sense of self as either as a solid entity, that we're a fixed being that is either good or bad, as I mentioned before, or whether we see our sense of self as something that is malleable, that is fluid, and that is capable of change. It's been shown that people who see their sense of self as more open and malleable and capable of growing are much more likely to say, I'm sorry. They're much more likely to say, you know what? That was my bad. I really should take responsibility for that. As opposed to somebody who has a more fixed conception of their sense of self, where accepting responsibility or accepting that there's been some transgression is equivalent to saying that they are a bad person. Hence, they're much more likely to avoid and deny. This is important in talking about rupture resolution because it's been found that the level of mindfulness that a clinician is able to exert, the level at which a clinician can be open in engaging this rupture resolution process can actually affect whether the relationship can be strengthened by this process or whether the relationship will wind up breaking down further and leading to the patient ultimately to drop out. This is relevant to the topic that I'm discussing today because we've actually taken a look at different kinds of ruptures that can sometimes happen across racial and cultural difference, which we sort of pack under the rubric of what's called microaggressions. Microaggressions are defined as the brief and commonplace daily verbal, behavioral, and environmental indignities, whether intentional or unintentional, that communicate hostile, derogatory, or negative racial, gender, sexual orientation, and religious slights or insults to the target person or group. So these are things that are not just comments, but also behaviors that are largely unconscious, that are operating without conscious awareness on behalf of the person who is engaging in them, and that often leads to a very ambiguous, sometimes weird sort of interaction. So to give a very specific example, I once went in for an interview at a particular internship when I was at a trainee. And you know, most interviews are about 30 to 45 minutes, gives you an opportunity to get to know the site, get to know the people you're going to be working with, and an opportunity for them, of course, to also get to know you. And no sooner than 5 minutes passed into the interview, the person interviewing me said, you know, I just have to notice you speak English really well. Like there's just no discernible accent. And I thought, oh, that's okay, it's fine. Yeah, I learned English at a very early age. I'm originally from Puerto Rico, but yeah, I can speak English. And I tried to then go back to talking about my interest in their side, and they say, no, but do you understand that you speak English really well? Like you must be really blessed. You must be genetically endowed to be able to speak English so well. And I thought, well, that's really weird. I mean, English is a language, you can learn it or not, but there's no genetic reason for me to speak English well. And so I tried to sort of address the point, but it was sort of flying over this person's head. And we really spent the entirety of the interview talking about my capacity to speak English or not. as opposed to my clinical skills or whether I'd be a good fit for the site. And afterwards, she noticed, oh, we're out of time. Do you think you could send me a clinical write-up of one of your cases? Because I noticed we didn't really talk about your clinical skills. Now, after I left the interview, I just felt kind of weird, and I wasn't sure what exactly happened. I just knew that I'm not sure if I'm going to be in the site next year. Right? So it's a very ambiguous, very weird interaction. No one, technically speaking, was saying anything outright insulting or bad, but it was strange. And it really impacted my capacity to be able to have a conversation with this person and for them to really get to know me, right, which is the purpose of any meaningful interview. So that's an example of what a microaggression can look like, right? Sometimes when we think of particularly racism and racially insensitive things, we think of very bombastic statements and racial slurs. But these are really very day-to-day comments that people sometimes make to each other that can make the interaction or the relationship sort of awkward and weird, and make, in this case, in the case of the client, make it unsure whether they can establish a trusting relationship. Now, in looking at the psychotherapy literature, it's been shown in studies that there's a range between 53 to 81% of ethnic minority patients in psychotherapy experiencing a microaggression at least once in their therapy. Now, if we look at the studies with the larger sample size, we see that the number really jumps from 50 to 81. It might be a little bit larger than that. Of the clients who experienced a microaggression, 76% reported that this was never talked about. And as we know from the rupture resolution research in general, when these ruptures, whether they're the teeny tiny ruptures that happen day to day or the big events that happen in the relationship, when they're not discussed, patients are much more likely to vote with their feet and leave. Like ruptures in general, they may not be discussed, patients may drop out, but also if they stay, they're less likely to improve. They're much more likely to experience poor outcomes. Now, alternatively, it's been shown that when you have a strong enough alliance, there's a capacity for the treatment to actually bear the brunt of these microaggressions, in part because they're able to be talked about overtly. O and Emil Tao et al. In their study argue that therapeutic relationship, particularly if it's sturdy, can create a relational base, which can enable the therapist and the patient to talk about these moments openly, discuss what happened, and of course their feelings and reactions to it, and in the end, be able to repair the relationship. It actually shows to function very much how it does in general psychotherapy, that when ruptures are present and when they are repaired, the relationship gets much stronger and there's actually better outcomes ultimately. So I want to reiterate at this point once again, it's not even the presence of microaggressions that is the problem, but it's our inability to talk about them. And when we do, we can actually help our patients much more than to avoid them or render them invisible. Alternatively, when we're able to exude what's called a multicultural orientation, where we're able to show a sense of curiosity and deep interest in the client, their culture, their background, their worldview, we're much more likely to strengthen the alliance and ultimately get more positive outcomes. Now, in the interest of time, I just want to share a couple of more thoughts before I end. There's been a very recent and very interesting meta-analysis that has looked at the role of multicultural competence relative to some traditional change processes in psychotherapy, such as the therapeutic alliance, empathy, general competence, and so forth. To make a long story short, it's been found across studies that when multicultural competence is present, the relationship between that and outcome is sort of mild to moderate, but the relationship between multicultural competence and other things such as empathy and the alliance are very robust. In other words, when multicultural competence is present, all these other things that we value and talk about, such as empathy, strong alliance, congruence, also tend to be present. Which means, in a sense, that all these things that we value and love and care about in our work, the alliance, empathy, etc., things that have been known to have a positive impact on outcome, often cross over a bridge that is often invisible, and that bridge is culture. When we're able to have a cultural bridge with our clients, these natural human predilections, empathy, connectedness, relationality, are able to cross over and lead to positive good outcome. However, when that bridge is broken, we're not able to engage in these natural human capacities in order to be able to help our clients. So part of what I'd like to leave you with today is this idea that we're all more human than not, and that these basic human capacities may be impacted by things such as implicit bias or misunderstanding, but that if we're able to address them, we can let our natural human capacities to do their work. Now, what can be done in terms of training? We know so far that the very same tools for managing missteps in psychotherapy and making connections can apply to discussions of race and cultural difference. Now, how do we inculcate those sensibilities among our trainees? How do we nurture them in a way that empowers them to use these tools, as opposed to making them feel that they have to walk on eggshells in relation to topics of culture and race? I want to share with you a couple of brief studies. One of them is based on a sample that was collected between class of 2010 to 2014 across 49 different medical schools. There were two very interesting studies that came out of this sample. One of them that looked at what exactly helps medical students be able to reduce their level of implicit bias. And in that study they found that completing and then having a space in which to discuss their results on the implicit association test during medical school was predictive of their capacity to have lower levels of implicit bias by the end of medical school. So it's just the act of completing this test, which is available readily online, and having a space to talk about it apparently seemed to make people more aware and to be able to use tools to correct those biases. In addition, having positive interactions with black physicians was also predictive of reducing bias, which brings us back to contact theory, that being able to have ongoing interactions with folks who are different from us, particularly if they're in a relative position of authority, can also have a positive influence. Alternatively, hearing negative comments about black patients from either other residents or attendings predicted increased bias, something that is often kind of invisible in our field. I remember sitting at a morning rounds, we were reviewing cases and talking about clients at an inpatient unit, and over the course of rounds, we talked about a particular white patient who was currently manic, and the attending physician was very empathic during their interview and tried to communicate in a way that they could understand, and ultimately made a referral for them to engage in group-assist medication, as they're wont to do. However, on a very similar patient who was also manic and experiencing the same symptoms, but who was also black, the attending's response was, "Oh, this patient's so ghetto." And they didn't engage in the same kind of empathy that they're perfectly capable of engaging in, but were impaired because of a form of bias. And of course, this was heard by the other trainees at the table, and you can only imagine, well, what impact did this have to see someone in a position of authority making these kinds of comments? Now, another study that also came out of the sample looked at differences in learning orientation, in looking at whether people were able to make use of this kind of training in medical school. Learning orientation is very similar to theories of the self, meaning that you can have a learning orientation in which you're open to learning from your mistakes and that learning takes place in a gradual manner, or a learning orientation in which you either know what you need to do and you do it right, or you don't, which can sometimes come up in medical school particularly. They found that, of course, individual differences in learning orientation moderated the impact of disparities training, meaning individuals who had a sense of self that was malleable, that saw this as a learning opportunity, were able to make the most of it, as opposed to trainees who saw this as, well, I have to be culturally competent, I have to know it from the get-go, and if I don't, I'm bad, I'm racist, etc. But more importantly, the learning orientation of the school had a much more powerful impact. So a medical school philosophy that encourages their students to learn from their mistakes, to see this as a growing opportunity, we're much more likely to have trainees who are able to benefit from this kind of training, as opposed to a philosophy that said, well, you either know these things, and if you don't know them, then you're no good. You're out the door, which generates ultimately a lot of anxiety. I'm just going to end here and bring up one final bit of data that's been looked at. Out of all the different variables that I've talked about, a person's level of implicit bias, explicit bias, whether they've been exposed to multicultural training, etc., one of the things that seems to come across as having the most impact is the student or the clinician's own personal day-to-day experience with people who are different. In other words, that as much as we talk about cultural competency as something that we do in our care with our clients, it seems that this is more importantly a lifestyle that there's only so much that we can gain from having trainings or workshops or even grand rounds talking about these issues when we see it only as something that's limited to our work as opposed to the worlds and communities that we go back to and where we go home to and the people that we relate to day to day. Now, aside from the training piece, I don't quite have an answer to that, but I think it's important to keep in mind that we live in an increasingly divided, binary, and segregated country and society, and that this can ultimately impact not just our own lives, but the kind of work that we can have with our clients. So I want to say, once again, thank you for this opportunity, and thank you for your time.